Hi, thanks for everyone. Thanks for taking your time out. Really, this was a bit of a project that Dee and myself have. Dee's been leading on it, and I've been working with and supporting it. And this is all about what's happened with the services in urgent emergency care over this COVID period. And really, we were trying to get to grips with how we all reacted to this COVID environment, and that's at all levels, in the nines, the ones. Sorry about this. I'm the first one to right. So, and therefore we looked at UTCs, and we basically visited all the UTCs within the region, and wanted to really have a conversation with them about the way they'd responded to COVID-19. Now, what was clear was that there was that originally there was some concern. There was really, we were trying to get to grips with what was going on, and there was a bit of a lag, understandable lag in general practice and in UTCs about really where do we sit in UTCs, because we sit between A&E and community. And then finally, when we did respond, we responded relatively well, but it's quite nuanced in different localities and different regions. So I think we want to share that story today with yourselves, and we want to share what the positive findings and also how we want to move forward with this. So I think that's really where this event sort of comes from. One of the questions we've been asked really is, what's the national perspective? What's the national thought on this? So I thought the best thing to do is actually ask Adam, who's the head of urgent treatment UTC program nationally. So I think if that's okay, so we'll start with Adam, if that's okay with everyone. Adam, are you with us?
I am. I was just unmuting myself and putting myself on camera. I'm not the most technologically competent person. Thanks, Pir. And can I just sort of apologise to you and to Dee for messing you around over the last 24 hours, just for everybody else. Although I'm sort of the head of urgent treatment programmes, particularly regarding the urgent treatment centres, I have just in the last week been redeployed onto COVID testing, particularly as the lead for the serology programme. And it's bonkers. It's like walking into a tornado, and you're hoping you're going to get into the middle of the tornado where it will be calm. But every time I walk towards the tornado, it picks me up and throws me off in a different direction. And that's happened this morning, I'm afraid. So I'm sorry about that. The next thing I think I would really like to do, because of sort of reflecting on the urgent treatment centres, and I've got to say the wider type 3, type 4 community in this, is to sort of say thank you from the national team, really, because I don't know if there's been much opportunity for people to do that. But we did some work for the Secretary of State last month, and it really highlighted to us the phenomenal contribution that the urgent treatment centres and the wider type 3, type 4 to some extent were providing towards the whole coronavirus campaign. And 146 of the urgent treatment centres stayed open and were operating throughout the early stages of the response. And in those few cases where sites were unable to continue as urgent treatment centres, it's because they'd been either given key roles in as part of local plans for COVID reconfiguration, hot and cold sites, etc. Or were doing in fact, in all cases, they were doing something like that. And so there is no doubt that the urgent treatment centres have played a very, very significant part in ensuring that localities can address the challenge of coronavirus while maintaining urgent treatment services to the population who still needed them. There was still a requirement out there. And even though there was, as we know, a sort of a significant drop in the footfall right across urgent and emergency care, it didn't mean that that requirement had gone away completely. So on reflecting on that and sort of looking to the future, there is a lot of learning, a lot of really worthwhile experience that will have developed over the last few months. And there's a real appetite to ensure that this is brought into business as usual as we go forwards. And the sort of the big ticket item that is going on at the moment, we have been calling 111 first, but is now going to be known as Help Us to Help You. And we are working very hard to ensure that the urgent treatment centres are part of the key deliverable as part of the Help Us to Help You. I don't know how aware you will all be of it, because I don't quite know how the communications of that piece of work have sort of spread out throughout the regions. But for those who are not aware of it, if I was to sort of to describe it very, very quickly, I would say that it is the sort of urgent and emergency care transformation program that's been running for some years with a rocket booster behind it. And a far greater impetus. We've been trying for quite some time to reduce the sort of the pressure on EDs, and this Help Us to Help You aims to do the same thing. But what it's doing is it's putting much more energy and effort and drive. And one of the side effects of the coronavirus period is we have learned how to change our services to adapt and to develop at a much faster pace than we've perhaps been able to hitherto. And Help Us to Help You is aiming to use that sort of that drive, that methodology, in order to sort of drive change and to reduce the burden on EDs, particularly with the expectation, of course, that one way or another the coronavirus is going to be around and with us for quite a long time, and it's all part of us aiming to protect that. And my strong viewpoint is that the urgent treatment centres should be at the centre of this. You know, we've got a significant number of sites where the urgent treatment centre is co-located with an acute trust. Not all by a long means, but the significant number of sites where they are collated with an acute trust. And many of those share a front door. And I know that you're going to hear about the experience of Greenbrook later on. And it's very, very interesting, their experience and what can be achieved where you have a really strong assessment at the front door of a combined ED and UTC run by an advanced nurse practitioner, and the effect that they can have in diverting patients away from the ED and towards the UTC. Part of Help Us to Help You looks at the delivery of, I will say booked appointments, but we'll say attendance slots. There are slight nuances in sort of the wording that go with it. But work is going on to look to see whether we can have appointments within emergency departments. And again, where there are urgent treatment centres that are able to sort of control that front door, you know, we are posing the question, because there is a strong assessment there, actually, does an appointment into an urgent treatment centre provide the answer to that question? Is that going to sort of deliver what is needed? So there are a number of strands within the Help Us to Help You that the urgent treatment centres are actually at the centre of. Linked into the whole thing are the ambulance dispositions as well, and work that's ongoing to really try to increase the prevalence of ambulance services taking patients rather than to an ED, but where it's appropriate, the disposition for the ambulance patient being to an urgent treatment centre. And these will obviously have to be worked through locally, but I think that what we're trying to do is to make sure that the drive is there, and the training is there, and the communication is there to make those things happen. And so linked into this is, and I'm rushing, conscious of time, and so linked into it is this sort of this growing importance, what I perceive as being the growing importance for the urgent treatment centres. One of the areas I just touched on there was appointment booking, and we know there have been significant challenges. It's fantastic that sort of the last set of figures I saw, we were sitting at about, I think it was 156 urgent treatment centres that had been established around the country, with a further 47 that were due to be delivered by the end of the year, and that's not including the areas where there are still consultations taking place. But of that 156, we've got 120 that have got direct booking deployed already, and that's really good news. But we're still very, very aware of the difficulties that not having these sort of the national standards in place have created. But we're now at that position where a number of providers are developing against the national standards Care Connect, including both at the 1-1 end, the sort of the requesting of the booked appointments, but also at the UTC end, and EMIS Symphony will be getting towards the point where they have almost completed their development. And so one of the big things that we'll be trying to push for now through commissioners and through yourselves is to lean on your UTC IT providers to develop against those standards, because they will allow us to really exploit direct booking into the UTCs and to make them much more effective, make them much more user-friendly, and provide a much better service. And so I feel as though, sort of, if one thinks of a log jam that we've had on direct booking, we're now at a stage where the logs that were closing the blocks have now sort of loosened themselves, are drifting away, and we're now getting movement. And so if there is one thing I could ask everybody to do on that, is to start having the discussions with your IT providers about developing against the Care Connect standards. The last thing I just want to talk about is my view on how we take this programme forward from where we are at the moment. Yes, there are still a number of UTCs that have yet to be delivered, and there are some localities where decisions have yet to be made. But actually, we've got a good number of UTCs that have been operating for some time now. We've got an awful lot of learning that's in there. And my personal view, and I just stress that it is my personal view, is that we're now getting to the situation where we are working against a set of standards and policy that was created some years ago, was published in 2017, and we are now developing learning which goes beyond that because of people's experience. One of the things I've been very impressed with, and I don't know how many of you will be involved with, are the forums that are put together within integrated urgent care, where they hold commissioner and provider forums to be able to discuss the realities of, in their case, operating integrated urgent care. But I would like to mimic them, to copy them within the UTC programme, to start really getting the learning from those people who are commissioning the services and need to make sure that the service that's being provided fits in with the wider UEC offer for their localities, and whether there are freedoms or constraints in the way they operate that they would like us to learn from and change things. And also from the providers, to be able to look to see from your experience what is the best practice, where do the standards, where do the policies perhaps not work quite so well, are there things that you've identified are particularly good and we should bring in there. And so we could start having a process of developing the policies around urgent treatment centres so we can, over a period of time, really optimise them to make sure they really can deliver to the best of their potential as part of the wider urgent and emergency care programme, particularly with this reinvigorised desire to reduce the burden on emergency departments. And I think with that, I'll stop because I think I was told to stop at 15:15. So, Pir, have you got any questions for me on behalf of everybody else? I sort of don't know quite know how you want to work it.
So I suppose one of the questions I have is, we want the UTC to develop its own personality in a way, don't we? We want it to have a clear plan. We recognise patient flow as a concern, and we've got to look at that in detail and how we manage that flow. But then we've got to really recognise what is the role of a UTC in a certain patch. And that's something that's going to be quite nuanced, I suppose. I don't know what your thoughts are, because originally it was very prescriptive, very defined, wasn't it, what we wanted UTCs to achieve and where we wanted them to go. So do we now have an element of understanding that for different patches there's going to be variation and we have to work with that variation at all?
We've always accepted in terms of how they will meet the need, there will be some variation, which is, you know, why the standards can be interpreted to, you know, against local needs, and there might be some work we need to do on that to sort of to help support that nuance. I mean, the fundamental we have to remember is the idea that there are two fundamentals. One is, if you recall, that the sort of the intent, the driving intent was to reduce confusion within the UEC space, so that patients knew exactly and could get used to exactly what was going to be delivered by urgent treatment centres, and they knew what it meant and they knew what they would get there. To take away that, I don't quite know what I want and where to get it, so I'll default to the ED.
Yeah.
And so we need to make sure that we are building on that and we develop that, and we find a way to reinforce it. Yeah. But it also ties into the fact that, you know, the second principle is drawing people away from the ED. Mm-hmm. And as we've seen, you know, we've you know, the sort of the key thing has been to get the idea out of a sort of a fairly consistent offer about what an urgent treatment centre is and what it does. It linking into local systems, and we've sort of touched on front doors of acute trusts where there is an ED. Yeah. But in terms of the footfall and the fact that sort of there's been a significant reduction in footfall, we are seeing nationally that there is a slow increase again, and it will stay slow, because I mean, a lot of people are still saying behind closed doors. A lot of people, you know, are still in that, I don't want to go near a healthcare facility because, you know, it's, you know, I'm not that poorly, thank you. I've only got a leg that's hanging off. And there'll be some people who have a sort of a worry about the dangers of going near. Yeah. So my expectation is on that there will be a reduction in the there will be an increase in the natural footfall towards the urgent treatment centres. Yeah. But two of the things that will come out of the Help Us to Help You is that if we can get more people using 111, and 111 can be sort of optimized, and there's a lot of work going on with pathways and DOS and various things to do with the providers as well. I think that what we will see, if that works, is we will see the patients, a greater number of the patients who come to UTCs who actually leave without any real treatment being needed, being diverted elsewhere. Mm-hmm. But we will see more and more people who would have gone to the ED being more effectively redirected to the UTC instead. So I would imagine that we will see a build up in the workload of the UTCs back to what level I wouldn't like to guess, but I would expect us to see a sort of a general increase in the acuity of what UTCs are dealing with, still within its capabilities, but by taking away some of the sort of one might call zero acuity work.
Yeah. Thank you, Adam. Thanks for your time. I was just going to move on and highlight a few things that we've found that Dee and myself well, when we've gone around the patch and had a chat with everyone, I've found, and I'm wondering if I can share that with everyone, Dee, if that's okay.
Yeah, if we can just draw on the other point that Adam wanted to make, which was around the National UTC Forum.
Yes. So one of the thoughts that we had was that Adam had was that we should have a forum where we can have these conversations. So moving forward, I'm hoping that's something we can actually drive and address. So Adam, would you like this to be a quarterly meeting where we can get people together, or a monthly?
Well, when I'm in the position to actually think,
Yeah.
my feeling is probably quarterly is more appropriate. I think that the issue we can have with within this space of doing things on a monthly basis is that people tire of them very quickly, and so my feeling is that quarterly is probably more appropriate. And bearing in mind that I see this as being 2 forums, not one. Is it forum or forum? Not quite. Forums or forum. I'm not quite sure. My Latin is rubbish. That's why I couldn't be a doctor. I see this the provider and commissioner fora being separate because I think they meet separate needs, and I think that we need to sort of allow both of them to sort of have independent thoughts and independent discussions, which we then sort of try to balance out. So I think that quarterly, but two meetings quarterly is probably the optimum. But firstly, I'm open to discussion on that, and when we get to the point of sort of coming out and consulting with the regions about what everybody thinks, we will consult on that. And secondly, we can get things started, and if we find that we've got the frequency wrong, then we can always adjust anyway.
Okay, so I mean, we're quite keen, which I'll talk about at the end of this this whole meeting, that about having a not effectively a forum, but actually moving that quite quickly and actually starting to look at things that we can address quite promptly. And I will share that with you. I'll share my thoughts with you on that later on, if that's okay, Adam.
Thank you. That'd be great.
Thank you. Thanks, Dee. Is there anything else, Dee? That can move right. Okay, so obviously, going through having these conversations with all of my colleagues in the region, the commissioners and the providers, there's a number of things that have come up. One that I was really blatantly obvious was that the biggest impact on all the services was that we had a significant reduction in footfall, and at that point we sort of had to work out where we stood as UTCs. We obviously had issues in terms of our guidelines. Our guidance, national guidance, was limited because we didn't really have a defined, were we sitting with acutes, were we sitting with primary care? That was one of our issues. The other was around PPEs. That was an issue that really impacted the whole service as a whole. And then the variance in digital solutions was an issue. However, what we did find is people went out and actually found solutions that would work for them. And actually, there was an element of how do we resolve the issues? How do we manage patients safely? And therefore, they went and addressed those issues quite impressively in many ways, really. So the main concerns, I suppose, I have now moving forward, where do we go with some of these changes? Do they stay, or do we move on? And in what way do we move on? COVID's not going anywhere. Winter's not too far. So are we prepared for COVID and winter? So is that something that we need to be thinking about? Are we able to manage our flows well? So the new ways of working that we've seen from some of our colleagues, we're going to be sharing today. But we really need to think about moving forward about technology. Can that actually offer us a hand? Can that help our flows? And then does that allow us to really define the role of UTCs in different patches? And actually we can then inform our patients and our population about what their UTCs do for them. And if we can integrate that well into primary care and to acutes and with the ones, then I think that's a good place for us. But I think it requires a lot of work from all of us, and a bit of a joint vision, really. So what we'll do is we'll move on to the next slide, and we'll let our colleagues share their thoughts with us. Now, before one of the ones were one of was Howard Finnegan and Zoe Rourke. So, what this is more about looking at technology and an attempt to resolve some issues using technology. So, if we go with Howard and Zoe and actually really listen to their thoughts and attend anywhere, and see if that would fit our UTC model.
Thank you very much, and thank you, Dee, for inviting us to join you today. We don't have too much time, so we're going to do a sort of whistle-stop tour around what is known as Attend Anywhere. I'm assuming that as a starting point, nobody knows anything about Attend Anywhere. It is basically a video consultation platform that was rolled out in Scotland last year, and there was a plan to roll it out across England over the next 3 to 4 years. And what COVID has done has accelerated that rollout of a digital solution into just a very small number of weeks. So next slide, please, Dee. So these are the sort of headlines. This has been a nationwide programme across the Midlands. All of our trusts now have video consultation in place. That's the community trusts, acute and mental health trusts, and we plugged the gap, the 46% without, with Attend Anywhere, and others are now moving across. Nearly 3,000 hours of live consultations using Attend Anywhere since the 1st of April, which is astonishing, and 8,500 consultations, actual consultations, with 3,000 clinicians signed up across the patch. Next slide, please, Dee. So the numbers are really quite impressive, and these mirror the performance across the country. It's been an absolute whirlwind and an example of how we can actually achieve a digital deployment when we need to. And I'm just watching in the chat area. Can I ask you, Zoe, to just pick up any things that are relevant whilst we carry on with the slides?
Yeah, of course.
Thank you. So we have trained 614 clinicians to use the system, and across 3 different sessions there have been 2,500 people trained. The next slide, please, Dee. So a bit of colour for a Thursday lunchtime. You can see there, I'm not going to dissect all of this, but you can see that from a starting point at the end of March, we've ramped up all the way up to 8,500 consultations, which is astonishing. That's 8,500 of the Midlands, where patients have been seen by clinicians without having to go to a physical meeting place. And all of the other consequential outcomes, such as people not having to travel, not burn fuel, not pay for car parking, all of those other benefits, if you like. So next slide, please, Dee. So the way in which Attend Anywhere works, and it is one of a number of different solutions on the market, the way this was offered into the system was that NHS Improvement signed a license agreement with Attend Anywhere, established a platform, an internet platform for NHS England, and it has basically been provided to trusts under a sub-license. It's not costing trusts anything at this point. There'll be a commercial model at the end of the first 12 months. So the way in which patients access video consultation is either through a front door type arrangement. This is a trust, NHS Airedale NHS trust in Scotland. They have a front door through their website, and you can see there's a video consultation button. So if we press that, next slide please, Dee. Or you can send a link to patients that's got the URL, as is in this example. Next slide, Dee. And this is what it looks like. I apologise for the breakneck speed that we're going through this, but I just wanted to sort of cover as much as we could. So the system runs on a desktop, laptop, Android, iPhone, tablet. There's no software to download. It is simply you follow a URL to a website, and this is what the patient sees when they first click on that that URL. Next slide, please, Dee. And this is what you as your clinicians would see. You have access to one or more waiting areas, and the number of people who are in the waiting area are displayed, in this case Joe Bloggs. The information that the patient types in upon entering the system is kept for the duration of the call and is then deleted. So there's no IG issues around storage of personal or patient identifiable data. Next slide, Dee, please. So this is what the clinician will see. So having clicked the name of the person in the waiting area, the clinician and the patient are then taken to a virtual space where this is the actual consultation, and it mirrors what you might see in a physical setting. It is absolutely astonishing the number of settings, the number of specialities that are using Attend Anywhere in ways that myself as a non-clinician I could not have imagined. So it's really important that for deployment of VC that it is influenced and led by clinicians, because it is the clinicians who understand their particular environment and their patients, etc. This slide shows how one could, or you don't need to go back, it's fine. Once you've seen a patient, the patient can be sent back to the waiting area from whence they came, or they can be signposted back to a new or a different waiting area. For example, if the result of the consultation is that as a clinician you wanted the patient to be seen by a colleague or a senior specialist, that is how it would work. So the things to be considered. Next slide, please, Dee. I can't remember what it was. Is there another slide to follow, Dee? I'm not sure whether you can still hear me because the slide seems to have frozen.
I'll send her a message. Dee?
I don't know whether I can still be heard. So I'm not wasting the time. I'm presuming that I can still be heard. So we know that there are the number of specialities. Oh, there we go. Thank you. And thank you, whoever that was. We know that Attend Anywhere has been deployed in well over 200 different services. And there are some examples there. And that number is growing at an astonishing rate. It's being used very, very successfully in ophthalmology in Scotland, all of the specialities you see there, and you can see their emergency departments. So definitely there is opportunity for Attend Anywhere or any video consultation software or solution in urgent and emergency care. And some of the issues that I heard discussed previously, this is a solution that is should not be dismissed. It's something that can be useful. Is there another slide there, Dee? Right, so things that we would ask colleagues to consider. How will patients access the service, whether it's going to be through a front door or whatever, or patient leaflets, or upon arrival at a treatment centre. There may be a notice on the door with a URL, and a patient could click it and have a consultation with somebody in the building without entering the building, for example, from the car. And we know there are examples of that happening to protect the parties from COVID risk. I'm not going to read through all of those, but what we, apart from the bottom right there, we actively encourage all colleagues to properly explore where Attend Anywhere, where video consultation can be used. It's being used for OD, for HR type things, and for interviews in obviously non-clinical settings, which is very innovative. And what we're finding is that this solution was offered to plug a gap, if you like, or to offer an alternative during COVID. And there are lots of other examples of how it can be used that are coming along. So I'm going to stop there for a moment and ask Zoe just to plug any gaps that I have left before going to any questions. So Zoe, have I covered pretty much everything there?
Yeah, I think so. You've covered everything, and we've addressed some of the questions that were asked. So
Great.
There was just a couple of questions about, is it an alternative to some of the other solutions that are being used? And I said, well, yes, it is an alternative, but we are aware of some of the trusts that use different solutions that have found Attend Anywhere has got different functionality. So it just really varies. Yes. We had a question just around, is it free? And just explaining that at the moment it was an offer for trusts as part of the COVID response. And obviously there are talks underway about how contracts and costings might work moving forward. And that's something that's happening nationally at the moment. But other than that, that was all we had.
Thank you.
Howard, I've got a quick question. I think it's sort of what Zoe touched on. So one of the ones, can you hear me? Yeah, it's Pir. Can you hear me? Hello?
Yeah, that's okay.
Yeah, Howard, can you hear me?
Yes.
Yeah, fine. So the question was really around one of the softwares that are being used for video consultation in primary care is Accurex, for example.
Yeah.
Now, and around Birmingham, it's being used by a lot of the GPs. Now, the question really is where UTCs sit is. It all depends on where you sit. So if you sit next to an ED, I suppose Attend Anywhere would make sense. But if you sit within the community as a UTC and you don't sit next to an ED, then the question is Accurex a better option? I suppose is the question. It's one of the kind of questions that that providers would have is what would fit them. So I suppose there's an element of where they've got to work out what works for them, isn't there? So that's one.
Yeah. It really comes down to that there are practical considerations in terms of the commercial model and the contract model.
Yeah.
But I guess the question is iPhone and it really is. It comes down to that basic level. Accurex is a proven platform. Attend Anywhere is a proven platform. It was introduced at the start of COVID as a known solution that could plug and go. Right. And that's what it does. It does connect with other systems, and that would have been seen previously as a downside. It's actually an upside because it works. So those kinds of discussions. I mean, there are issues around contracts because the type of contract under which the activity is delivered in an urgent treatment centre. Yeah. That is an important issue too. So yeah, I don't know whether I've answered the question, but the fact is that can we use video consultation in this setting? Yeah. And if the answer is yes, then it's time to then look at what's going to work best and fastest. Attend Anywhere is available to trusts and it's free.
Yeah.
And that is one heck of an incentive.
Yeah.
That's all I'll say.
Yeah, great. Okay. Thank you, Howard. That's very good of you.
Thank you.
Thank you for your input. Yeah, that's very helpful. It'll definitely stimulate conversation between us, and hopefully in these forums that workshops we hope to develop, this is something that we may have to bring you back for a bit more detail, if that's okay.
We'd appreciate that. I would simply say that the video consultation work that's been done throughout COVID, it's not going away. Yeah. It's a real game changer. So we'd be more than happy to come back and talk. And also, you're all invited to contact us directly if you wish to, just have a conversation, learn more about it. So thank you very much.
Thank you.
Zoe and I now need to go off to another meeting. So enjoy the rest of your meeting. And thank you.
Thank you. Right. So we're gonna right. So I asked Vishen. I actually badgered Vishen, and he's terribly busy. But he's somebody I work with nationally, and it's always a pleasure to listen to Vishen because he really looks at these issues and problems quite globally. He really addresses all elements in the service he runs down south, and I'd like him to share his thoughts on how we can manage flow, and his thoughts on what the new UTC potentially can be like or can become, because it sits in between these different services. But I'd like his thoughts on where these things fit in, and it's all about integration. That's the essential bit here. So Vishen, thank you for joining us. So sure. I'll let you carry on, and I'll keep quiet now.
Okay, thank you, Pir. Thank you for asking me to join this forum today to share my thoughts. In terms of my background, I'm a GP in Hertfordshire and St Albans, and I've got a lot of experience now working with 111 since around 2010, and currently in post as regional advisor for the southeast of England, so Pir's counterpart down south. But I'm also a local urgent care lead for 2 CCGs and an ICS. So I get to see what it's like at commissioning and operational level, as well as at digital solution level from NHS Digital, because I work for NHS Digital as well. So I've got a mixed bag of roles. I think it's good to start by pointing out that, in January this year, we published the NHS long-term plan, which promoted digital everywhere. And it was a journey that we were going to go on over the next 5 years and then the second 5 years thereafter. COVID came along, and one fine Monday morning, most of us reached our practices and we had to shut the front doors, which meant we very quickly had to start thinking of different ways of being able to see our patients and provide some degree of care delivery. And we know now that meant that tools like online consulting tools, some of those we've already mentioned earlier today, as well as video consulting tools have been rapidly deployed across primary care. And I would put out that, this slide that I've shared there is pretty much the digital phone triage model that primary care is considering and has deployed now. I must point out that, we've deployed a lot of infrastructure. So, people have now been enabled with virtual desktops, remote logins, webcams, etc. What we're now seeing, especially in the last week or 10 days, is as the system is starting to go into recovery mode, we need to make sure that we embed these principles of virtual consulting and other ways of working, rather than slipping back to the older way of working in the past. And when I look across the system broadly, we know that secondary care is in specialities like pediatrics and gynecology and renal medicine starting to employ mechanisms of alternating outpatient appointments with a video appointment. And it's now up to our part of the system, which is the UEC part, the urgent and emergency care, to also look to transforming, but at the same time taking small steps to achieving a better way of working in this post-initial COVID phase prior to winter coming. And winter, we know, will be here in 12 weeks' time. One of the things that we need to ensure is the reduction of spread of nosocomial infection by people in the general community gathering in our waiting rooms. And this is a huge problem because, you know, the last winter that went by was pretty terrible for most of us who have responsibilities for EDs and UTCs. You know, it was a hard winter, and if we overlay COVID on top of that, then we're certainly not projecting an easy winter for 2020 and beyond. Now, in my own areas, we're looking at mechanisms to assess patients. We're looking at mechanisms of making sure we use 111 as that digital front door into UTC and into ED. And I'm going to talk about a little bit of some of the work that's happening in London and the Southeast that I'm actually directly responsible for, where we're trialing a concept of 111 first, where patients will not be brought into an emergency department unless they've had a screen via 111. But aside from those pilots, it's actually, this is an opportunity here because patients are also warmed up to the idea and concept of being assessed and understand the risk of being in waiting rooms and departments waiting for input. We've got, you know, doctors and clinicians willing to accept this, patients willing to accept this. So it's us as system leaders to actually deploy and facilitate a different way of working. And I'm just going to stop there for a second to see if anybody has any points or questions, because I just want to use the last few minutes to tell you about what we're doing in my own areas in Hertfordshire, outside of my NHS England role, to try and meet these challenges.
Thanks, Richard. Richard, do you want to share your, would you like to share your thoughts on what you're doing in your packs?
Yes, so in Hertfordshire, you know, we're looking at, we've done a bit of scoping over the last sort of 8 to 12 weeks of video consulting tools that can be deployed in integrated urgent care. We recognize that companies like AcuRx have had and established great market presence in primary care. However, we're still unclear on the longer term pricing models for all of these products. So we're slightly careful about what's being offered to us for free, because, you know, we're just wary of a sting in the tail later on in terms of the actual cost of these mechanisms. But what we've done as a first step is we've pretty much rolled out direct booking into all of our UTCs from 111. We've got direct booking into general practice up and running. We have invested heavily in our IUC CAS to ensure that we've got multidisciplinary teams there to deal with a lot of inquiry. Our provider is developing, and we're soon to launch an in-house mechanism of switchable consultation. So if you're consulting with the patient, you can switch on video for a component of your call and switch back to audio or telephone for the remainder. Because what we're finding in primary care is actually the video calls are taking longer. So there's certainly going to be a sort of capacity issue in trying to deal with everybody using video. And not every case requires video. And I see video as an adjunct to telephone, where actually the telephone is the primary medium of assessing and contacting patients, and switching to video for a part of the consult, like looking at somebody's cellulitis or a rash, or to observe something else that the clinician sees as useful, but also a mechanism of capturing that and embedding it into the notes. So we're starting to do some of that as well. And we're also now working with our acute trust to get direct booking into children assessment units into gynae clinics, into clinics for suspected DVT, to avoid that ED being that the filter in. We're still going to let patients come in through to our EDs, but we're certainly going to encourage those who use the mechanisms to get indicative slots of when they should be arriving. So these are kind of the work that we're doing across same-day emergency care in line with the GIRFT program, as well as aligning to some of the early principles of 111 first as well. I'll just stop there.
Time, sir.
Sorry, Pia, we can't hear you.
Can you hear me now? Thank you, Vishen. What we're going to do is move on, but there are a number of questions. What I'll do is I'll share them with you, and if you can then respond to them later on, if that's okay.
Sure.
We're going to prepare an FAQ document.
No
Thank
problem.
you. So we'll move. Once again, thanks, Vish. We'll move on to John Craig and Parmjit Ray, and the reason for asking John and Parmjit to present is they've got quite a novel primary streaming processes that they've developed down south, and I'd like them to share with us. Really, they're outside our patch, and they can give us a different perspective or a perspective of how they've managed this situation. Thank you.
Thanks, Pir. Hi, I'm John Craig. I'm the medical director and a GP. And Parmjit, do you want to introduce yourself?
Yep. So I'm Parmjit Rai, the operations director for Greenbrook Healthcare.
Thanks.
So thanks. Could we have the next slide, please? Thank you. So briefly, we are an organisation that has 10, it will be 11 on the 1st of July, sites across London and the South East, principally co-located urgent care centres. I know there are more ways that than one to skin a cat. Similarly, there are different models of UTC fitting into the NHS England spec, but we I've lost the okay, I will continue to talk, but we have a single model that we apply across all of our sites. Do you think we could have the...
Yeah, apologies, I'm not sure somebody was sharing their screen then.
It's all right.
Okay, is it not back on mine?
Nope, not yet.
Okay, is that working?
Yeah, we can see it now, Dee. Thank you.
For some reason, I can't see it.
Oh.
Which is not ideal. Anyway, so we, as I said, we have a primary care based approach. We control the front door, and we this model allows us to see, treat and discharge about 75% of walk-in patients, and we also would deal with somewhere between 50 and 60% of all A&E attendances. It starts with sorry, I can't see the. I'm sorry, I'm doing this from memory now. It starts with an emergency. Wonderful, thank you. Starts with patient booking in at reception. Clearly, if they're obviously having a heart attack or their legs falling off, they would be waved straight through to resus. But the main principle is that they are seen by a streaming emergency practitioner who is a band 7 person who's been trained and gone through a competency assessment. That's it's not a triage, it's not room based. There are different areas in which we stream, but usually it's with the patient standing up if they can, brief targeted observations and a history ruling out any red flags. And from that, the streamer will make a decision as to where that patient needs to go. So that's the first large column. If they're very poorly, then they would go to ED. If they are under 2, because under 2s can show subtle signs of more serious illness, we have a fast track, a brief assessment. If they need an urgent assessment according to our criteria, we'll see them within 20 minutes. But otherwise, all patients are seen on the 4-hour clock, as they are in all UTCs. But that second blue box there, redirection, is a key thing, even pre-COVID, but even more so now. So on discharge, obviously, we could send people to specialty. We could send people into the emergency department if they have deteriorated, or we can send them to community services, or discharge to their GP. But also, importantly, signposting to other healthcare and non-healthcare support with the patient champion. Now, so Parmjit is going to speak about the patient champion role for redirection. Our redirection is a clinical decision, as you can see. So it's made by the streamer according to a set of clear criteria with exclusion criteria for safety, but then is executed by the patient champion. So if you could put the next slide on, that would be great. And Parmjit's going to speak to that one.
Thank you, Dee. So as John was saying, the patient champion role, this is a unique role to Greenbrook Healthcare, and it is an intrinsic part of our clinical model, developed to improve the patient experience and enable patients to access healthcare in the right place at the right time. It's very much a patient-facing role, very visible, identifiable, reception-based, or within proximity of the waiting area. It's a non-clinical role which has 3 core functions. First is redirection, supporting the streaming nurse, as John described. Second is GP registration. So across a number of our UTCs, we have patients that are not registered with their GPs, and their default will always be the UTC. So a core function for the patient champion is to support patients. So even though they've booked in and they're waiting to be seen, in the meantime, the patient champion will take them away, go through the practices that may be taking new patients, or where they can register and book them an appointment at that practice, which we then follow up as well. So we do monitor the number of successful GP registrations, and that's really key in terms of educating patients and making sure that they have access to a GP to manage their ongoing healthcare needs. The third core function of this role is the health promotion, social prescribing, it's the self-care management. So that can happen either when we're redirecting at the front, or it can happen once a patient has been treated. So for example, if there is somebody presenting, it's asthma, diabetes, we will give them information and advice that's available to us in terms of how they can manage their condition and what they need to do. Some CCGs have behavioural change workshops, so we can register patients into those workshops. It's very much dependent on each CCG and what's available. In order to overcome some of the language and cultural issues and support education and advice and meet the diverse needs of our population, we have in 3 of our sites now, we're working jointly with the third sector, where we actually deploy health connectors that work closely with the patient champion. And the health connectors come with a range of different skills, different languages. So that really helps with some of the diverse needs and challenges that we face, and it's working really well. The other part of our model is community champions. It's where we're able to go out to communities and actually, so these will be communities that are already have forums in place where we can go and outreach and talk about healthcare and the appropriate use of 111 and the UTC. Where we've had the patient champion role well established, we have seen that over the last year or so, attendances to the UTC has plateaued, whereas other areas we've seen a significant growth. So this role can be very effective in educating patients and you know, ensuring that patients are aware of all of the services available, but this is very much subject to what is available in primary care and in the community. Next slide.
Thank you, Dee. I just wanted to briefly talk about how we've adapted due to COVID. One of the principal things that we did quite quickly was recognise that we needed to send people with potential COVID symptoms, but who were well and had minor symptoms away, which was why we put in a supernumerary, some people call it a welcome nurse, a hello nurse, we called it a COVID screening nurse, right at the front door before they even get to the registration and streaming that I was talking about with the first slide. Interestingly, that this has kind of evolved now. When the numbers were really low, as they were a month or so ago, they've certainly picked up since. The role was actually identifying those quite sickly people who needed transfer straight to the ED. There are a lot of people turning up huffing and puffing with SATs in their boots. So it sort of morphed into sort of patient safety role at the same time, but now it's turned back into a redirection role. Obviously, as everybody's done, we've developed hot and cold pathways and zones, and the biggest issue now is waiting room distancing. We have biggest site, Northwick Park. An average day, 350, 370 walk-in attendances, went down to about, I don't know, 60 or 70 a day at the peak of phase one. It's now back up to the sort of 200 level. So we are putting in place very careful waiting rooms distancing models, only letting an attendant person in if the person's frail, or if they're a minor, or they have a mental health issue, perhaps, those sorts of things. But also putting into place mechanisms whereby we're sending people out to wait in their cars if they need to be in the UTC. However, many people don't need to be there, and we are I've talked about a redirection policy already. We're trying to enhance that. We get to between 5 and 10% redirection on a busy day pre-COVID. I think that there's if we squeeze the tube a little bit tighter and tighten up on our redirection, we can get more out back home to self-care or to be dealt with by primary care. And then the real big stuff that we're doing right now is we already have put into place mechanisms by which we can support 111 and CAS queues, using the capacity created by reduced attendances to allow doctors to support stuff on the phone. But this is now developed into video consultations, as we've been hearing about previously at one of our sites. But we are now moving, as was mentioned right at the beginning, towards the help us to help you principles, which for me, at the front door, we physically stream people. If we are moving people into and what will need a big public health campaign into phoning 111 first, the idea then is that we will also virtually stream people. In other words, we will validate the 111 ED and UTC dispositions, such that if they need to be with us, we can make an appointment to control the flow, or we can send them to primary care, or we can arrange a home visit, or we can arrange whatever other appropriate appropriate care they may be. So I think that those 111 primary care dispositions that we're currently helping out with are going to be shifted more into primary care, and we'll be dealing with more of the ED and UTC dispositions. And this is the future proofing stuff as well. This is allowing us to deal with COVID and reduce nosocomial infection, but it's certainly what will allow us to more effectively manage the flow when it comes to just normal winter pressures.
And I think just to add, we are doing quite a lot of work with primary care, the GP federations, PCNs, just looking at how we're going to integrate more using the patient champion model and redirecting so that we create capacity for the ED dispositions in UTC, and really moving some of the patients out, as Adam mentioned earlier, that have low-level primary care needs into primary care or the hubs.
Thank you. John and Pandit, thank you for that. Now, moving forward, because we're hoping to develop this forum, if we asked you to come along and really talk about this in a lot more detail, would you be able to do that for us?
I'll be happy to do that. Yeah, of course.
Thank you. It's very kind of you. Thank you for your time. We're just going to move forward, and the reason is because we're a bit behind, and we're going to allow Hereford and Worcester, Vocare, Malling and DHU to share their experiences over the last few months in terms of how they managed this difficult situation and what are they doing, what are their thoughts moving forward. So let's start with Hereford and Worcestershire first, if that's okay. Thank you.
Okay, colleagues, so it's Chris Cashmore here, so the urgent care lead for the CCG, and I'm joined by Tristan Brody online, who's our urgent care lead GP. So this presentation really is not as much detail as the others, but it's just showing you a flavour of what happened in our patch. So the first slide, this would be familiar really to us all in terms of Kidderminster being one of our biggest MIUs in terms of the activity dropped in half. And if we fast forward, Dee, to the next slide, the same happened to our Bromsgrove MIU. If we fast forward, Evesham MIU was and Malvern. So just if we just hold there for a second, so the flavour for our MIUs, and we have 5 of them in our patch, is that for 3 of them activity has halved, and for 2 of the MIUs we actually closed them during the COVID outbreak, and they remain closed now. So just at this point, really, it's about telling you our story, and I think some colleagues would be wondering why we still refer to them as MIU. So in our system, we've previously tried UTC examples and co-located them next door to EDs. And what we have found is that that model served really to generate activity that was hitherto not there originally. And we're all conscious that the models of care we want to deliver are those that take activity away from EDs and not just generate or foster new activity. So we're very fortunate to have a county that has 5 MIUs, and those MIUs, that model is very well understood by the public, and it's really well supported by strong primary care. So what did the impact of that MIU experience have during COVID? Negligible, really, in terms of we didn't see that footfall present at ED, and neither did we see it present really in terms of into primary care. So there's a question for us all to answer as we come out of COVID and we start to resume business as usual. What we can't just do is switch on the floodgates in terms of for all this activity. Obviously, we know that we need to deal with the urgent activity and pick that up, but we just need to be conscious that we were dealing with demand that was just generated through services, and actually it's understanding about where that demand went, where it's best placed, and how we can keep that going. For the 2 MIUs that we closed 2 of the MIUs, one in Evesham and one in Tenbury. And what we actually feel as a system is the resource that gave back to the system in terms really helped us in terms of a home first mentality. So Tenbury, for example, is a out of the way area in Worcestershire, and very difficult to get packages of care, etc. So those patients that we wanted to exit from the hospital that would usually reside in Tenbury, they would always face 1 or 2 days delay within the acute trust. So actually, by releasing that those staff there, we were able to actually reduce length of stay for those patients in the acute trust by getting them home first quicker. So that needs to be within our mindset going forward about the continuation of that. Dee, if we can go forward a slide, please. This is really interesting. So this shows this groups all of our MIUs together in terms of their activity, and you can see how it's plateaued. And then the top line, the orange line, is seeing that ED attendances are going back to pre-COVID levels, whereas that sort of journey, the journey on the way back, we're not seeing that pretty much in our MIUs. So ED's getting busier, MIUs are pretty much staying flat. So if we fast forward again, please, Dee, can we go forward one more? So what we've underdone is, like we all do as systems on a yearly basis, undertake our services in terms of our patch. So we've reviewed the MIUs, and what we want to do is pretty much been the theme of this conversation, is to encourage fundamentally access to MIUs also through 111. So actually empower 111 to try and increase the utilisation of those MIUs and have a mixed mode model initially where patients can self-present, but also that we can book them in via 111 stream them there. And we're looking at one of our MIUs in particular, the Bromsgrove MIU, which is based quite near to one of our acute sites, and to expand the offering there primarily around minor illness, etc., and some consideration in terms of developing one of the strands of the UTCs in terms of the primary care hub model. So our story really is the changes in the MIU landscape through COVID not really impacted on ED. There's been positive stories in terms of the resource that they've given back into the system that have been able to support us in the community. And our direction of travel now is going down the direct booking of appointments into these to try and take that ED activity away. The next few slides, it's Tristan to speak really about how primary care supported our model. So forward one more, please, Dee.
Hi, Chris. So can we, this is really, could we give us sort of a brief summary? I think we're a bit short of time, so if that's okay, of what Tristan's thoughts were moving forward. Would that be possible at all, Tristan?
Yeah, sure. I'll keep it as brief as I can. So I'm Tristan Brodie. I'm the GP Urgent Care Lead for Herefordshire and Worcestershire CCG, and largely an in-hours GP. So just the historical context of primary care that allows us to have this model whereby that we don't rely on urgent treatment centres. The way we're arranged within the geographical area is that there are sort of a few relatively large organisations with 2 federations and a super partnership. There are some independent practices as well, but it means that there's clear lines of communication towards what, like I say, quite large primary care organisations, which I think helps the dialogue with both the acute trust and the CCG. We've got really well-established PCNs with collaborative CDs, both collaborative with the CCG and with each other. I know they have regular WhatsApp chats and regular meetings, both pre and post COVID. And historically, we've always been good at managing same-day demand, as we've not had walk-in centres or urgent treatment centres, and that work has been largely soaked up by general practice. Based that on sort of historical good access data. So within, for example, Wyre Forest and South Worcestershire, there's about 40% of our patients can get same day appointments with their GP, as opposed to a national average of something like, I think it's 33%. And also our out-of-hours provider is well respected and well used by patients for when we're shut. So all those things together have meant that we haven't relied on the UTC previously. If you could skip to the next slide then, which is the last one, and I'll just summarise that one, Dee, if that's okay, which is just really summarising our response to COVID. And a lot of this will not be unique to us, but the context that I've just discussed regarding the setup of primary care locally meant that we could take on a lot of the urgent care work, particularly the management of minor illnesses through the remote working for 95% of our patient contacts. Red and amber hubs, like most surgeries, have set up, some of these based across an entire PCN, which has helped as well with good IT support to cross-book appointments. And as I said, those good lines of communication with the CCG and the PCNs and the clinical directors. Also, more recently, if we're honest, we have noticed a trickling of sort of primary care patients going to the ED, perhaps because of the hub setup that we've been operating. So, but because I've been urgent care for a little while, I've got a dialogue with with both primary care and the emergency hospital teams, and currently acting as a bit of a broker to understand where there's gaps in the system, which are not the faults of individual clinicians or practices, but because of the national directive to work in hubs. So again, we're sort of fine-tuning the process as we go along, as we all are having to work on the hoof at the moment. So yeah, that's our background, and that's really all I had to say. Thank you.
Thank you, Tristan and Chris. Again, what we'd like is for you guys to be part of that forum, if that's okay, moving forward, and actually have these conversations with our other colleagues and actually find solutions for a lot of the work we do in our own patches, if that's okay.
Sure.
Thank you. Shall we carry on with Wolverhampton now, if that's okay? This is Iram Qureshi and Jack Butler.
Yes, thank you. Thanks for the chance to present. I know we're really pushed for time, so I'm actually going to hand straight over to Dr. Qureshi, and she's going to take you through the changes, if that's okay.
Thank you.
Hi.
Yeah.
Hello, Erin.
Thank you very much for asking us to join this forum. I'm just going to briefly take you through what we have done so far during. Hi, are you able to hear me okay?
Yeah, we can hear you.
Yeah.
Yep, we can hear you.
Yeah,
we can hear you.
Okay. So as COVID, are you able to hear me?
Yeah.
We can hear you, Iram.
Hello?
Yeah,
Okay.
Iram, we can hear you.
Okay.
Right, okay. So yeah, that's fine, thank you. So in Wolverhampton, we very quickly moved to robust triage first model. And in that, initially, we used to have face-to-face patient assessment directly booking in by 111 and through various other services. But with this triage first model, we were able to do robust triage, only bringing in patients who are really needed to have face-to-face assessment, and then the rest were dealt over the phone. We did organized triage training for all our GPs, nurse practitioners, and so they were all up to date. During this response, we worked very closely with our emergency department, which we are co-located in the same building. And we redeployed our triage nurse downstairs so that we would have single point of access for the walk-in patients. And that has worked really well, so that we are, as a Green Book colleague and other colleagues previously have said, so only bringing in patients who, or directing those patients to ED who really need to be there, and the rest primary care patients attended the center. And that helped patients, as well as managing the queues and the footfall in the urgent treatment center in itself. During this COVID, we worked very closely with WMAS, and our IUC providers here in the area, and we supported 111 CAS queues. So we were able to have 111 primary care dispositions, direct bookings into the center. So essentially, we offer direct bookings, roughly about 40 appointments every day, Monday to Friday. And that did took the pressure off 111. And certainly, we were able to call them and then guide them or redirect them to the GP surgeries, or deal with them over the phone, or bring them into the face-to-face assessments. We did remain in touch with the clinical navigators every day to help the queues, and that has really helped in our fight against COVID, or deal with COVID here in the area. One innovation, obviously, as already been said, development of the video consultation model. So the one query or one sensitive issue regarding verification of deaths, especially, was come up, and we worked with our CCG and our RIT team to do video consultation with that, especially with that aspect, and it has worked really very well. We did organize and help and support the nursing home or the care home colleagues, so that we are able to look into that further, and that worked. Locally, we did supported a COVID management service, and I myself was involved in bi-weekly CCG meetings, as well as meetings with the local CDs of the PCNs. And when the hot hubs were developed, we were able to provide support to them, especially in out of hours. But recently, there was a question of, obviously they wanted to take the lead or give the lead to the out of hour provider with regards to hot hubs. We always, right from the beginning, we were supporting that, and now they are closed over the weekend, and we are taking that, access, especially with regards to managing all the hot hub patients over the weekend, especially. As our Green Book colleagues have said, for the welfare of the patients, and especially those patients who were not registered, we have always worked in Wolverhampton UTC very closely with RMC, who is an organization looking after patients who are like migrant or those who are not registered. And especially in COVID scenario, although they were working remotely, we were working very closely with them. So any patient who has been in touch, not registered, we made sure that they are registered with their GP or a GP surgery, and then their needs are catered for. And we managed to look after our staff with a minimal, or as needed face-to-face assessment, and only one staff was off sick with COVID, but we have managed pretty well.
Thank you.
If you go next slide, please.
Can I just say we're running out of time? Can we sum up quickly, please?
Yeah. So as in recovery phase, we are working very closely with our local infection prevention team, and to maintain the social distancing measures in the center. And certainly, we would like to continue with the single point of access and we would like to hold the front of the house to be run by the UTC. And certainly that would help the primary care patients, and certainly to take the pressure off ED. And certainly we are capable, and certainly we would like to utilize the discharge at triage, so that the face-to-face capacity is adequately achieved. And certainly we would like certainly some of the things like video consultations in future, and this is how we plan to work.
Thank you, Arum. That's very kind of you. So we're going to move on. And again, I think we'd like to bring you to the forum and actually have these conversations in a lot more detail about how we streamline these patients into UTCs. In your case, it's co-located. We realize that. And you've done lots of very good work, which is appreciated.
Thank you.
Thank you. We're going to move forward to Malling, if that's okay. Sorry about it. We are a bit behind. I apologize. But let's get Malin to do their thing.
Hello, thank you very much. My name's Lola Ramon. I'm the operations manager for Dudley Urgent Treatment Centre. If you'd like to go to the next slide. Thank you very much for inviting me to this forum. We're co-located with Russell's Hall Hospital. We're effectively the front door of ED, so we're the gatekeepers in that sense. At the moment, we actually stream up to 60% of the patients who attend the ED department to the urgent treatment centre. So clearly, we have quite a high acuity of patients in that sense. So 24/7 walk-in access to the service. We also provide bookable appointments and home visits for cases referred via NHS 111 during the out of hours. We also provide the excluded patient scheme at that location as well. So it's quite a limited location, limited estates, but we try to manage that as effectively as possible. Okay, could you go to the next slide, please? Okay, so for us, in terms of trying to manage this COVID situation, initially when we started, we were advised to close the door, but clearly being at the front of the ED department, that's not something we could do. There were patients that needed to attend who were very ill, that may have had COVID symptoms, so we needed to make sure those patients were seen. So the first thing that Malin did is we provided the COVID management service, and this was a service where we monitored patients over a period of time, patients that had symptoms that may have had underlying health conditions, and we monitored them at home. So we would call them on a regular basis. So each day they'd get a single call, we'd check their symptoms, ensure that their symptoms hadn't got any worse, and if they hadn't, we'd just call back the next day and monitor until we knew that they were safe enough to come off the COVID management service. For the CMS, the referral was either via the GP surgeries from primary care or referral from NHS 111. So during the out of hours, we were able to transfer patients who we felt needed to be monitored into that CMS so that we could keep everybody all within one area to keep sort of monitoring them. It was good in the sense that regardless of where they presented from. So if they presented from the urgent care centre and we felt that, oh, this patient, although we'd monitored, we'd had consultations with them, if we felt that, look, this person needed to be on that service, there are underlying conditions, it was good that we were able to sort of take that from the out of hours side of things, from the walk-in centre side of things, and from the primary care side of things. So it kind of joined everything together in that sense. It was very difficult in the urgent treatment centre in the sense that with very limited space, once we social distance everything. So in terms of, could you go to the next slide, please? In terms of sort of making sure chairs were facing the same direction. We had to put 2-metre gaps in between all the waiting room chairs. It meant we were only able to fit 14 patients inside our waiting room. And at times we can have up to 35 patients actually coming through the door per hour. What this meant is that we had very large queues. We had to make sure everybody was social distanced. So for us, we had to make sure that every patient was given a fluid repellent mask because we had to be able to identify which patients needed to be there and needed to be seen in the ED department. So it wasn't as simple as sort of just sending everybody home. We converted 2 of our consultation rooms into isolation rooms, and we actually also had an isolation roster. So those patients that were that had any symptoms were only seen by these particular clinicians. And for us to be able to make sure the clinicians were confident enough to do this, we needed to go over and above the PPE that was suggested at the time. So I went out, I got hazmat suits, I got everything, despite them being told at the time that we only needed sort of fluid repellent masks. We didn't know whether these people were COVID positives. They were only displaying symptoms. So for me to be confident, for those clinicians to do that, one of the learning I got from that is to make sure they've got everything they need. Okay, if you want to go to the next slide. Obviously, with the patient volumes, practically half or even less than that during some of this period coming into the urgent treatment centre, what we found is that the triage calls increased significantly to about, I think, 86 or 80% triage increase as a result of us trying to push people to be dealt with via over the telephone. moving forward, as the volumes begin to continue to increase, our further challenges is how do we manage sort of patients at the front door if we've got 35 people waiting outside the front door? How do we manage that? We do have 15-minute streaming and assessment at our front door for us to identify those that can wait, those that can be seen and treated, and those that can be sort of just sent home again. But as the volumes increase, these people will be waiting outside. So our challenges now are, how do we manage those queues in the front? How do we make sure those people are safe to wait? How do we redirect from patients queuing? How do we make sure that we ensure our 15-minute assessment stays up and over 80% and get that up to 95%? And how we also utilise the estates that we've got at the moment to be able to move forward. And PPE, of course, making sure that as an organisation that isn't actually an NHS organisation, that we have continuous access to PPE that clinicians feel comfortable to work in and confident to work in.
Thanks, Lola. That's been really helpful. We'll have to move on to the next presenter now. So as Pir said, Pir, do you want to do the follow-on?
Yeah, so Lola, we know there's a lot of work that you've done in your UTC. So again, we'd like to invite you to the forum and be part of that solution and conversation. So we're going to let DHU, because DHU does some really interesting work. Let's Simon, you want to go with it? Thank you.
Hi, yes, thank you very much. If you just go to the next slide, please. And the next one, thank you. Oh, just go back one. Okay, thank you. Simon Harris, Managing Director for DHU. If you just give a very brief overview, only got a handful of slides. So Leicestershire and Rutland is a 1.1 million population, a single acute trust and a single ED, which is unusual, but there are 11 urgent care centres, 3 of which are designated. And there's just a single urgent care provider in DHU. So the immediate impact that we felt was that face-to-face activity dropped by 50%. And you can see there that the CAS, or the clinical navigation of that activity, increased by 40%. And that was relevant across all the country, I think, particularly through 111. So that required an immediate review of all internal pathways and IPC measured. Staff clearly worried and concerned, as was every member of the public. So very quickly we needed to segregate and cohort patients. We were asked to do a number of tasks, of which one was the swabbing of the staff and carers across LLR. We also did the home visits for LLR for all the swabbing of patients, and this resulted in a longer call cycle times, mainly because of the IPC measures that were just put in place. If you go to the next slide, please, Dee. So what we did in partnership with Primary Care was very quickly establish 3 hot clinics. They opened up on the 6th of April, as you can see there. 2 of them were hot and cold sites, with one just being hot, and that was a brand new site, so it wasn't a site previously used by DHU. The hot clinics were 10 till 8 for 2 of them, and 2 till 8 p.m. The normal opening times are different from that. One of them is a 24/7 urgent care centre, and the other one was a traditional 8 till 8 urgent care centre. And the pathway was developed in partnership with Primary Care, which I'll come on to the pathway on the next few slides there. But what that meant effectively, that all practices could book directly electronically through System 1 to book their patient in. There was also a telephone video consultation with the practice and the patient prior to attending. And what that enabled us to do was apply the cohorting principles for the patients. So both the patients were protected, but also importantly, the staff and the surroundings were protected. And if you just go to the next slide, please, Dee. So here is just an overview of the pathways. So for the hot site, the patient first of all speaks to their own GP through telephone advice or through video consultation, and then they make the referral through to the urgent care centre electronically through System 1. When they arrive at the urgent care centre, they're asked to remain in their car. And a clinician goes out, as you can see there's an example, goes out and just does some basic observations with the patient in the car. And then what happens after that, the patient then does a video consultation with the clinician in the urgent care centre. And if they don't have a mobile device, we provided them with that mobile device. It's through Accurex, as we've discussed previously earlier on the call. What that allowed us to do was to ensure that anybody who did need to be seen absolutely needed to be seen, but if they were symptomatic but stable, the patient was then kept safe and then returned home. If they needed a prescription or treatment, that treatment was delivered out in the car park. If they needed a fuller workup and a face-to-face assessment and observation, they would then be invited into the urgent care centre, into the designated hot area of the site. So we actually managed to cohort patients across both sets of sites. For any cold patient that presented, the patient would self-present or book through 111 as per normal, or book through the GP practice. In the urgent care centres, we triage and assess those patients in the vacuum. So rather than them entering into the urgent care centre straight away, we ensured that they were safe to be entered, and if they didn't need to enter, i.e. something could be done very quickly to ensure that patient is turned around, or a simple prescription or clinical advice, they'll be diverted back home. So it kept the patient safe, and it didn't then congregate lots of people in a waiting room, which we know can get very, very, very busy. If you just go to the next slide, please, Dee. Thank you. So the considerations what that meant for us, as others will have found, there was a significant increase in the overall consultation time, mainly through the pathway changes, but also through the IPC measures that were put in place. But what that enabled us to do across particularly the urgent treatment centres, but also in the home visiting that we have for 24/7. That allowed us to cohort patients. So we had hot sites and cold sites, and we also had hot and cold teams, which they changed obviously on day by day, but they would remain for that particular shift, whether they would be seeing hot patients or cold patients. So it kept it segregated. Most of primary care now, that was kept safe. So the decision across LLR by the clinical leads was that primary care, core primary care, was then kept more as a cold site. There were isolated areas where they would set up hot clinics, but the vast majority of patients that were COVID symptomatic outside of ED would be presented to one of the 3 designated hot clinics, all through the home visiting service. Other aspects that we needed to change was the layout of the centre, so different reception area and different waiting areas. And also the pace of change, as we'll all recognise, was significant. That included DOS changes, PPE usage, patient communications to ensure they're kept informed, and the challenges, along with informing primary care and other health partners and social care partners across the system. But I think overall that the process worked, and the key learning areas for us were actually the video consultation worked. And it was agreed with primary care that the clinician who was seeing that patient had the right then to do the second video consultation with the patient to actually determine whether they did or did not need to be seen. And I think the reason that some of the patients were not seen is because of the different risk thresholds, and probably the different risk appetite, and also perhaps knowledge in urgent care as opposed to that within core primary care. Okay, thank you, Dee. Thank you, Pam.
Thank you. That was excellent. Thank you. So I'll be very brief now, because we're well over time. What I'd like is actually for us to develop this forum and actually have these very open conversations and about genuinely finding solutions, which is what all of the providers we've just talked to, who have just presented their work, have done exactly that. So I think we need to share these ideas really. The footfall is going to be a problem for all of us. Winter is around the corner. IT solutions are something we need to seriously look at and see what else we can get from IT. We need to manage these flows as soon as possible moving forward, and have clear plans for all the services within the region. We have to work together on this, because that's definitely the way to address these issues quickly, effectively, and safely. So I'm hoping you guys are all with me on this, and I'm hoping moving forward we can have these conversations in a forum and find solutions to these problems, and actually find novel solutions. Thank you for your time. There will be responses to your questions, and we'll send that back out as a document. And thank you, Dee, and thank you, Chris, for helping me through this, and thank you for everyone for joining me today on this. Have a good day. Thank you. Thanks, Dee.
Thank you. Thanks, Pia.
Thank you.